this is Dr. Carrie Jones, Medical Director for Precision Analytical Dutch Test. Today we're going to talk about reviewing the hormone basics, how to functionally address premenopausal women and their hormone symptoms. So today what we're going to talk about are things such as your estrogen and progesterone, testosterone, DHEA, symptoms that are involved, testing, and then what you can do about it. This is a basic overview, but I hope that it gives you enough clinical pearls and actionable items that you can help your patients and your clients right away. So let's review the stages of life, just so we're all on the same page. Premenopausal women, a lot of times it gets confusing. This is not perimenopause, this is premenopause. So this is a woman who still cycles. About after 30 years old, only 10% of a woman's non-growing follicles remain. This is really important for those of you who are doing fertility work. And it does take about 70 to 80 days for a follicle to go from that pre-antral phase all the way up to a dominant follicle, which is about 3 menstrual cycles. This is important for treatment. So when you're doing herbs and nutrients and hormones, you definitely want to give it about 3 to 4 months so you can go through that entire development process. A perimenopausal woman, typically between the ages of 39 and 55 years old, and this is when the HPO axis is really not that regular, the communication is starting to change, and she is having all sorts of symptoms. Maybe she had very regular cycles her whole life, and now she's starting to skip cycles or have short cycles or long cycles. She's likely not ovulating all the time, and that results in low progesterone. She's probably experiencing things like hot flashes and night sweats, joint pain, some brain fog, maybe weight gain, and things are just not what they used to be. A menopausal woman is once a woman has gone through 12 consecutive months and has not had a period. When she's 12 months done, she is menopausal. The average age is 45 to 55 years old, and in fact, the Mayo Clinic states that the average age a woman enters menopause is 51 years old. This, of course, varies depending on her diet and her lifestyle and her genetics. It depends on her mom, her grandmother, older sisters, her aunts on her mother's side of the family. A postmenopausal woman is the point when all the menopausal type symptoms have stopped and she's not symptomatic. She's not having hot flashes or night sweats. Her hormones are probably pretty low in the menopausal range. And they say that this is typically a 55-year-old woman and older. So as you get into your 60s and 70s, of course, you're pretty postmenopausal. Let's look at some graphs. When you're looking at the menstrual cycle, this is an example of a woman who still gets her cycle. It's the normal rise and fall every 26 to 30 days. Each of these rise and falls of the blue and the red lines is one menstrual cycle. So you can see this is 3 cycles. It's very consistent. It's very normal. Then we look at the bottom at a menopausal woman, a postmenopausal woman. At the very, very, very bottom of the slide, or of the graph, I should say, you'll see her estrogen and progesterone are right along the bottom, and that's normal. Her ovaries and her adrenals, they're not putting out very much estrogen anymore, and it's very consistent. She doesn't cycle. She doesn't go up and down. And then you'll see the dashed lines are her FSH and her LH. That's communication from her brain, her pituitary, and they're trying to tell the ovary to make hormone. But of course, she's postmenopausal. So those levels will be higher because they're yelling at the ovary, essentially, who has shut down. It's menopausal. Then we get to that period in between known as perimenopause, and it's basically just mad chaos. The hormones are going up and down. Sometimes she's ovulating, sometimes she's not. She's skipping cycles. She's having 2 cycles in a month, and it's just kind of all over the place. And a lot of perimenopausal women can relate. They say that they have these symptoms that come and go, symptoms they never have, they have now. And so it can be difficult to test as well, but we're going to talk about that. So common concerns we're going to discuss today: elevated estrogen, decreased progesterone, elevated testosterone, and of course we'll touch on 5-alpha reductase, decreased testosterone, and we'll talk through some of the examples and symptoms that are on the right side. So we'll explain like luteal phase defect, your women with PMS, we'll go through a PCOS case, of course some fertility, we'll talk about libido, and then all the symptoms that are associated with this up and down. Now people will say, well, why do you have hot flashes and night sweats listed there? This is a premenopausal talk. Women can experience hot flashes and night sweats at any age. Yes, it is absolutely most common in the menopausal or perimenopausal time, but for sure there are women in their 20s and 30s who will say you know what, I have definitely had hot flashes in the day, or I'm starting to experience night sweats as their hormones start to change. This is what your typical normal menstrual cycle looks like. It's very regular. In the beginning of the cycle, progesterone should be very low, but estrogen starts to rise. Estrogen gets this healthy rise we call it the late follicular phase. So the follicular phase is the first part. That rise in estrogen triggers your LH. LH triggers ovulation. And then what's left over is called a corpus luteum or corpus luteum, depending how you say it. And that corpus luteum is what makes progesterone. So if you have a woman that's not ovulating, she is not going to make progesterone. This is really important for things like menopausal women or perimenopausal women where ovulation is shut down, it's not happening anymore. Their progesterone will forever be on the lower end. When do you test? I get asked this question all the time. So if she's still cycling regularly, if you have a patient and she gets the typical 26 to 30-day cycle, you want to test her on day 19, 20, or 21. If she has long or short cycles but they're regular, for example, if she is consistently 35 days every single month, you're just going to shift her collection time up appropriately. You would shift it up 7 days. So instead of collecting on maybe day 20, you would collect on day 27. If she's consistently short cycled, for example, if she cycles every 21 days, you would just shift her collection down. But if she's irregular, let's say she says, you know, some days I'm 60 days, then I skip a cycle, then I'm 28 days. I really just don't know. I'm all over the board. What you can do is you can have her go buy ovulation predictor kits, which are sometimes called OPK, or also known as LH kits, LH for luteinizing hormone, at any pharmacy or grocery store. She would urinate on one every morning from the start of her cycle until it's positive. And when it's positive, that indicates she's about to ovulate in the next 24 to 48 hours. Now, she would stop those kits once it's positive. She will count forward 5 to 7 days, and then she will collect her Dutch test, and that's when we get the appropriate timing for her cycle. If she's not ovulating or she's really irregular all over the board, then I joke and say we guess and hope for the best, but it's a little bit true. So we try to catch based on her last cycle. We look at her history of cycles. If she's not ovulating, in that case, she may be a really great candidate for our cycle mapping test, which is when she collects almost every day following a calendar, and we map it out for you to let you know what's going on with her cycle. Why is she so irregular? And when is her ovulation happening, or is it even happening at all? So if you have a patient that falls in this no ovulation, weirdly irregular category, definitely talk with the lab, call the lab, and let's get a cycle mapping test for your patient. Okay, so now we're going to talk about each hormone, what makes them high, what makes them low, and some of the symptoms that are associated with each. Let's talk estrogen, because that's the big one everyone wants to know about. Estrogen dominance, estrogen cancer risk, estrogen deficiency. You have 3 estrogens as a woman. So E1 is the weakest. It's also known as estrone. It is the most abundant in menopause, but not as abundant in the cycling years. However, it's still really important because E1 can be made from testosterone. E2 is the most potent, and it's made primarily in the ovaries. E2 is what we look at when we're looking to see mostly with estrogen dominance, estrogen dominant type symptoms. And of course, E2, much like E1, as it goes through detoxification, can go down the wrong pathway and increase the risk for cancer. E3 is what's known as a metabolic waste product. Basically, it's the weakest estrogen, and it is the dead end estrogen. Once E3 is made, then it is cleared out of the body. However, it's really elevated in pregnancy, and E3 is really important for the tissue health in the vagina. So if you have a woman that's experiencing vaginal dryness and her E3 is low, that could absolutely be the reason. Estrogen does a lot of good things. Estrogen is not this villain that everybody paints it out to be. So it really is helpful, of course, for growth and development of female secondary sex characteristics. Super important for implantation. All your patients who are trying to become pregnant, estrogen balance is important. It increases vaginal acidity to help protect against infections. So if you have a woman who has chronic yeast infections or vaginal infections, check her estrogen. If she doesn't have enough estrogen, if she's estrogen deficient, this might be the reason. I've already touched on the fact that E3 is really helpful for vaginal lubrication. E2 especially is helpful for bone health. There are women who are experiencing osteopenia or osteoporosis. Check her estrogen levels. It's helpful for the brain. It's helpful for collagen production. The less estrogen a woman has, she tends to report she has more wrinkles, her skin is thinner, and she feels like she's aging faster. It does help protect against atherosclerosis. Now, this is endogenous production. This is the production that she makes, as opposed to hormone replacement therapy of estrogen. And estrogen through the estrogen receptor, ER stands for estrogen receptors, does help induce or upregulate the expression of the progesterone receptor. What this means is when estrogen comes out in the follicular phase, it pushes the progesterone receptors to come out in the uterus to be ready for implantation. So if you don't get that estrogen rise in the follicular part, then you may not get very well or healthy implantation in the luteal phase. So estrogen is important for fertility. Of course, too much estrogen can lower the thyroid hormone. It can block conversion of T4 into T3, and estrogen can raise thyroid binding globulin and will then lower thyroid hormone. Now, too much estrogen can do a lot of other things, such as it can raise cortisol binding globulin. That will render your free cortisol too low, but that's a different lecture. And too much estrogen will raise prolactin. And we will talk about prolactin in just a little bit. So, why does estrogen decrease? What would cause it? Well, of course, over time, as a woman ages and becomes perimenopausal into menopausal, her estrogen naturally goes down. If she's having irregular cycles or she's skipping cycles or she's not ovulating, now most people would think, well, then shouldn't she be estrogen dominant? Not necessarily. If the ovaries just aren't working that well at all, she's not going to make any hormone, including estrogen. Anorexia. Anorexic women tend to lose their cycle and therefore their estrogen decreases. Anorexic women are at higher risk for bone loss, of course, osteoporosis and osteopenia, one from loss of nutrients because they're not eating or bulimic, but also two because of this loss of estrogen. A woman who has very low cholesterol might have low estrogen. So cholesterol is the backbone to all hormones, which you will see a couple of times through this lecture. If a woman is extreme exercising or training, extreme CrossFitters, marathon runners, that can often result in a lack of a period or irregular periods or anovulation. I had a patient who was an extreme marathoner. She ran marathons or half marathons almost every weekend, and she was trying really hard to become pregnant. And it turned out with all of this extreme training she was doing, she was causing her menstrual cycle to not be as efficient, so to speak. Like she would have these really weak periods, she wouldn't bleed very much, or she wouldn't have a period at all. When I advised that she should probably stop her marathon training, her periods came back, and within about 3 to 4 months, she became pregnant. Extreme stress will result in skipped menstrual cycles. A lot of women have experienced this either through life stress, illness, then they'll skip a cycle and their estrogen will be on the low side. Under appropriate body weight, this may not have anything to do with anorexia, but it could definitely be, think of your sports, your extreme sports people, your athletes. If you think about like in the Olympics, the gymnasts, there is mixed research on it, but the what's out there suggests maybe under 15% body fat can result in amenorrhea or loss of a cycle. And then of course she has low estrogen. If she's experiencing hypogonadism, which means that her ovaries are failing, she's not going to make estrogen. Hypopituitarism means that she's not getting the communication from the brain down. She's not going to make estrogen. Anything that decreases blood flow to the glands, such as even smoking. Smoking will decrease blood flow. Diabetics, having that increased sugar, the sugar is clogging to the capillaries, and then she's not going to get healthy estrogen output. Breastfeeding, of course, hypothyroidism, PCOS. Now, many people think, oh, PCOS is estrogen excess. It could, except if she's skipping cycles, then she's going to have very low flatlined estrogen. Fertility medication will often result in low estrogen. Opioid pain medications. Now, with the opioid pain medication epidemic that's happening, not many people realize the effect that it can have on the entire HPO and HPA axis. So definitely screen your patients to see if by chance they are taking any medications. And the medications can actually take effect within 2 days on the HPO or HPA axis. In fact, I recently was consulting with a provider, and her hormones were very, very low when I brought up opioid pain medications. And the provider said, no, 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 she's not on any opioid pain medications. I would know about it. 20 minutes later, the provider calls me back and says, you're not going to believe this, but she does pain medications 2 to 3 times a week as needed recreationally. I was like, recreationally? So just be aware, talk with your patients about it. And then, of course, lastly, the hormonal birth control. So if you have a woman who is on the pill, the patch, the ring, the implant, the injection, anything that will stop the hypothalamic pituitary ovarian communication for birth control purposes will render estrogen on the Dutch test to be low. Speaking of birth control, let's talk about birth control. So the birth control pill stops the FSH and LH surge from the pituitary to prevent an estrogen rise. This, in fact, stops ovulation. The point of the pill, the patch, the injection, the ring, the implants is to prevent pregnancy by preventing ovulation. So if you're testing a woman on any of these methods of birth control, her hormone levels should be quite low, estrogen and progesterone. This means that the birth control method is doing its job. It's working, and she's not likely to become pregnant. So don't think that if you see really low hormones on the Dutch test for her estrogen and progesterone, that something is wrong. It's she's on birth control. So always ask your patients about that. If your patient decides she wants to stop her birth control, she should probably wait about 3 menstrual cycles to do her hormone test with the Dutch test. So if she decides, you know what, I'm going to stop my birth control pill with this next menstrual cycle, then 3 more cycles she waits, and then she does the Dutch test. The reason is the first cycle after a pill is, of course, pill-induced. It's not really her HPO axis communicating. The second menstrual cycle after stopping the pill, you're hoping that her brain and her ovaries are communicating again, and then that period should be more normal. And by the third menstrual cycle, you're hoping the pill is out of her system and it's her actual brain to ovarian communication, that HPO axis is working. Now, if she stops her pill and pregnancy is a concern, please remind her to use backup protection or consider an IUD, such as the copper IUD, for hormone and pregnancy purposes. So speaking of IUDs, what about the Mirena? So the Mirena is the progestin-only IUD, and a lot of people think, oh, it's progestin, it's local, it's just in the uterus, no problem. Well, in fact, that's not true. Some susceptible women find that it can partially or fully suppress their ovulation, and that will render their progesterone low. It doesn't affect the rest of their hormones necessarily. Their testosterone, their cortisol, their DHEA will all be whatever it will be. And unfortunately, there is no test to know ahead of time who is susceptible. So the hormone test in the luteal phase, you just do it like normal. So day 19, 20, 21 of a typical 28 to 30 day cycle. Shift up if she's a long cycle, shift down if she's a short cycle. You don't have to change your testing method. Just know with the Mirena, the progesterone might be low. The Paragard, otherwise known as the copper IUD, does not interfere with hormones per se. There is no hormone in the copper IUD. Okay, what's the opposite? Why would estrogen levels increase? Obviously, the more weight a woman has, the more her estrogen can go up through aromatization. Testosterone will convert into estrogen in fat tissue through the aromatase enzyme. Diabetes, PCOS. Now again, remember I said PCOS might result in low estrogen, which is true. If she's gone 4, 6, 8, 10 months without a menstrual cycle, she probably has really low estrogen levels. If she's just not ovulating, but she is getting this up and down with PCOS, she may be estrogen dominant. Estrogen supplementation, of course, will result in higher levels. Steroid medications. So think about people who are doing topical cortisone creams, steroid inhalers, steroid nasal sprays for allergies. Poor liver clearance. So if the liver is not able to effectively move the estrogen out, the estrogen will build up. We've already talked about aromatization. Environmental estrogens, of course, these are ubiquitous. We can find them all over. They do not show up on the Dutch test, however, but they can result in estrogen dominant symptoms. Alcohol will raise estrogen. So research shows that 2 or more glasses a day can raise estrogen levels through the liver. Ovarian cysts, the theory behind that is maybe the cysts are pushing or acting on the ovary, and therefore estrogen goes up. And then the Mirena IUD, which I did not talk about in the last slide, but there are several women on the Mirena who find that, of course, they may have a partially or fully suppressed ovulation, therefore their progesterone is low, but their estrogen also goes up. And the mechanism of action is not quite known. And I don't mean just general or relative estrogen dominance. I mean their estrogen actually increases. So, and again, the mechanism is not known, but we do see it all the time. So symptoms of low estrogen, we've talked about this. These are your low mood, like depression, vaginal dryness, low libido, hot flashes, joint pain, night sweats, thinning skin, what have you. Estrogen elevation are the opposite. These are your PMS women, mood swings like anger and irritation, heavy bleeding, which is known as menorrhagia, cramps, fibroids, weight gain, water retention, tender breasts, thyroid issues, and of course, cancer risk. All right, let's talk about progesterone, our progestational hormone. So this is made in the ovaries only after ovulation. If she doesn't ovulate, she doesn't make very much progesterone. In 24-hour and in dried urine, we look at the two estrogen metabolites, the A-pregnanediol or alpha-pregnanediol and the B-pregnanediol or beta-pregnanediol. Now, these are really important because the A-pregnanediol converts into the neurosteroid called allo, and that crosses the blood-brain barrier, and that activates GABA A receptors. And GABA is your calming, relaxing, everything's going to be okay hormone. So if you stimulate your A-pregnanediol, your alpha, then you're going to stimulate your GABA A receptors, and your women were going to have less anxiety and improve sleep. This is best done through oral or sublingual progesterone supplementation. Some women just genetically have higher alpha-pregnanediol. When you do the Dutch test, you'll see it's just genetically higher, and so they're not as prone to anxiety and insomnia. The other interesting thing is as a woman gets older and moves into menopause and her progesterone levels drop, she may find that she is more prone to anxiety and insomnia than she used to be. Again, she used to have the protective alpha-pregnanediol in a healthy range, and it's dropping because of age. And so now she says, oh my gosh, I used to sleep really well and I don't sleep as well anymore, and I'm more of an anxious person. What's going on? And you can say, it's your alpha-pregnanediol. So progesterone, I always say progesterone, again, the calming, relaxing, everything's going to be okay hormone. Helps with sleep and anxiety, which we just talked about. It is an antagonist to the mineralocorticoid receptor. So this does help quite a bit with water retention. Now, too much progesterone, especially in the form of supplementation, can worsen water retention, but your own endogenous progesterone production can actually help counter it. Of course, progesterone is called progestation hormone for a reason. It's great for helping with fertility and implantation. When pregnant, it decreases the maternal immune system so that your immune system does not attack the fetus and allows the fetus to grow. It does help with sex drive. It helps with neurons in the brain. In fact, it's often given in really high doses after stroke or traumatic brain injury to protect the brain. It does enhance serotonin receptors in the brain, which is great for those who experience depression and anxiety. It is an antispasmodic and it relaxes smooth muscles, especially in the lungs. But women with heavy cramps may notice when they do progesterone or get their progesterone back on track that their cramps significantly decrease. It does reduce gallbladder activity, whereas high estrogen is the opposite. High estrogen will increase gallbladder disease. Progesterone is the counter. And it does help prevent endometrial cancer, whereas estrogen is the opposite. High estrogen can cause increased risk of endometrial cancer. Why does it decrease? Very, very similar to the estrogen reasons, so I won't go into all of them. But of course, age over time, again, irregular cycles, anorexia, low cholesterol, extreme exercising, extreme stress, body weight, hypogonadism, hypopituitarism, breastfeeding, thyroid issues, PCOS, opioids. And here's an interesting one, NSAIDs. So these are like diclofenac. So these are over-the-counter pain medications. Naproxen. Research shows after just 10 days of use, it will suppress ovulation. So when I have patients that are looking to become pregnant or we're trying to make them less estrogen dominant, then I will say, hey, look, we have to find an alternative to the NSAIDs that you take for pain medication because they are suppressing your ovulation and therefore suppressing your progesterone. And we don't want that. The Mirena we've talked about, and of course the birth control pill. The birth control pill will shut everything down. Why does progesterone increase? Well, naturally with ovulation. With support, certain supplements such as Chaste Tree, which is also known as Vitex, will increase it. Pregnenolone will only increase progesterone metabolites, but does not increase actual progesterone itself, which I know lots of us were taught differently, that if you give pregnenolone, you'll raise progesterone. It turns out that's not true. So to raise progesterone, the body will pull cholesterol into the cell and then into the mitochondria. Pregnenolone happens to be a stop on the way. Mitochondria do not steal from each other. So we hear all the time, oh, it's the pregnenolone steal. No, once your cholesterol is in the body, in the cell, and in the mitochondria, they can't steal. Pregnenolone absolutely works though. It is a neurosteroid. What happens is pregnenolone turns into the alpha pregnanidyl, which is that progesterone metabolite. That goes on to make allo, A-L-L-O. That crosses the blood-brain barrier and it works from the brain down. So people will say, well, I give my patients pregnenolone and they feel better. They're less stressed. They're less depressed. They're less anxious. Absolutely. But it works from the brain down, not because of direct increase of progesterone. And then lastly, progesterone supplementation. So progesterone creams, progesterone vaginally, oral, sublingually, those will all raise progesterone levels. Progesterone imbalance symptoms are very, very similar to the estrogens, the high estrogen symptoms. Low progesterone causes PMS, anxiety, insomnia, fertility issues, mood issues, water retention, heavy periods, cramps, low libido. High progesterone, and this is specifically due to supplementation. If you put a woman on progesterone and she says, oh my gosh, I'm breaking out, I'm feeling a lot of water retention, I'm having tender breasts, often due to water retention, she's on too much progesterone, or maybe she needs some liver support to help clear it out. All right, prolactin. Now, prolactin is not tested on the Dutch test, but I feel like it's a really important hormone to know because it can cause a lot of problems when it's out of balance, and it's directly influenced by estrogen and stress. So prolactin is the prolactation hormone, of course. As prolactin goes up, a woman is able to breastfeed after she's given birth. Now, prolactin is directly inhibited by dopamine. So if somebody's dopamine is off, they may have higher levels of prolactin than they want. And this is regardless of their breastfeeding. If they're not breastfeeding, a woman can absolutely still have mild to moderate elevated levels of prolactin. Dopamine is really critical here. And prolactin can suppress ovulation. So if you think about your patients that breastfeed, they don't tend to ovulate when they're breastfeeding regularly because breastfeeding at prolactin suppresses ovulation, which of course then suppresses progesterone. But over time, as the breastfeeding gets less, then they start to ovulate again and their cycles resume. Now, this is what's interesting on prolactin. High estrogen, low thyroid, and high stress can raise prolactin. Now, remember, prolactin is the lactation hormone. So the body says, hold on, prolactin's kind of high, maybe mildly high. I don't really know what's going on here. I'm not sure if we're breastfeeding or not. So it starts to shift the cycles. Maybe she's anovulatory. She doesn't ovulate. And maybe she starts to have nipple discharge and she's not breastfeeding. So it's really important to check prolactin if she's experiencing these symptoms or if you notice that her estrogen's high or cortisol's high or she has low thyroid. All right, speaking of breastfeeding, can you do the Dutch test or any hormone test for that matter while you're breastfeeding? The short answer is, well, it depends. If she does have her cycles back, even though she's breastfeeding, then test like usual. Do it in the luteal phase. Do it in that day 19, 20, 21 of a typical 28-day cycle. However, if she says, well, I cycle, but they're kind of irregular because of breastfeeding, you can consider doing those ovulation predictor kit tests, the OPKs, until they're positive. Once it's positive, stop those, count forward 5 to 7 days, and do the Dutch test. If she has not yet gotten her cycle back and she is breastfeeding on the regular, be aware if you do still choose to do any type of hormone testing with her, they'll likely be really low, potentially. And that can be normal because it's the effect of breastfeeding. That's what prolactin does. So you may want to wait until she gets at least one cycle, maybe two, and then you can do the hormone testing. Okay. We've talked about estrogen, progesterone, prolactin, and now we're going to start talking about some of the androgens. Okay, where are androgens made? Well, it turns out they're made a couple of places. Ovaries, the ovaries make 25% of testosterone through LH stimulation of the theca cells, 50% of the androstenedione, and 20% of DHEA, not DHEAS. Remember, DHEAS is the sulfated form, hence the S. The adrenals make 100% of the DHEAS, 80% of the DHEA, 50% of the androstenedione, and 25% of the testosterone, just like the ovaries. So if you have a woman that has low testosterone or high testosterone, it could be an ovarian or an adrenal issue. The adipose tissue makes 50% of the testosterone through the conversion of androstenedione. So it's important to know your androgens are made in a few places: the ovaries, the adrenals, and your fat tissue. So testosterone is increased, of course, with supplementation. Now, if a woman's taking testosterone, it should go up. Also be aware testosterone contamination. So if a woman has a partner, perhaps a male partner, who is using topical testosterone cream, she has to be really careful not to get contamination on her skin from him, because that will, of course, result in higher androgens. The higher a woman's insulin is, the higher her androgens. PCOS, again, often it's insulin-based, but it could be adrenal, which we're going to talk about, will result in higher androgens. If a woman has low sex hormone binding globulin, she will have higher free testosterone because sex hormone binding globulin binds up that free testosterone. If she has hyperadrenal output, again, the adrenals make testosterone, androstenedione, and DHEA and DHEAS, she might become symptomatic. Now, unfortunately, testosterone decreases with age. We all know this. Women, as they enter into menopause, will report they're losing their sex drive, they're losing muscle mass, their mood is changing, and testosterone can play a big role with that. Low ovarian and adrenal output, again, poor communication from the brain. Zinc, vitamin D, and vitamin A can play a big role in testosterone production. Low cholesterol levels, low precursors like DHEA, so if she's not making very much DHEA, she may not make a lot of testosterone. Just like with the other hormones, decreased blood flow to the glands can be a problem. So smokers, diabetics or pre-diabetics, any kind of surgery in the area, perhaps she had exploratory surgery or she had scraping due to endometriosis. And, even though doctors and surgeons do the best they can absolutely bump and move blood vessels, capillaries, and then that results in less hormone. Diabetes we talked about, and then, of course, elevated sex hormone binding globulin. So the higher the binding globulin, the lower the testosterone. That leads us to what is 5-alpha reductase. This is on the Dutch test. People say, I don't understand the difference between a DHEA, a testosterone, and a 5-alpha reductase. So the 5-alpha reductase is the enzyme that converts testosterone to the most potent 5-alpha DHT. So DHT is what is responsible for things like acne, hirsutism, which is facial hair growth in places that women don't want, hair loss on the head, and mood swings more on the anger irritation side. The 5-alpha reductase is increased with genetics. Some people, unfortunately, just have higher levels. Inflammation will push that alpha pathway. Higher insulin, and of course obesity, because this can often happen in the fat tissue. So 5-alpha reductase, it's important to have it in a balance, but too high can result in a whole lot of symptoms. So let's talk about common problems and move into treatment. Estrogen dominance. Estrogen dominant, but why? There are a lot of reasons for estrogen dominance. It could be a SNP problem, genetics. It can be environmental estrogens. Maybe she's on too much. Maybe it's relative to her progesterone. And there's a whole list, which we've already talked about. And maybe it's detox. So let's talk about detox. If a woman has estrogen dominant symptoms, you can see here on a snippet of the Dutch test, her E1 is high at 38.9, and her E2 is high at 4.9. But if you look at the 3 arrows under that, that's her phase 1 detoxification. And my goodness, she prefers way too much of the 4-OH, the 4-hydroxy. That's at 2.5. So she has a sluggish phase 1. She's supposed to go down the 2-hydroxy, and she's going down the 4. And you can even see her 16-OH, her 16-hydroxys at the upper end. These are just recirculating out in her system and causing a lot more estrogen dominance on top of her already high E1 and E2. This is a before and after DIM. In fact, this woman took DIM for just 2 weeks, and in 2 weeks you can see all of her markers dropped, and she starts to favor the 2-hydroxy, which is fantastic. So keep that in mind. If you do DIM or I3C, indole 3-carbinol, it will lower E1 and E2 out of circulation. Be very careful with your menopausal women. I know this is not a menopausal lecture, but if you have a menopausal woman and she's experiencing hot flushes, night sweats, brain fog, and you put her on DIM because you're trying to help her phase 1, you might make her symptoms worse. So in that case, you may have to adjust your dose down, or you may have to focus on other products like sulforaphane or glucoraphanin. That's what's in broccoli sprouts, or maybe focus more on phase 2. So speaking of phase 2, this woman has really high 2-OH, and then when you go through methylation, methylation is the act of phase 2 detoxification for estrogen through the SNP COMT or COMT. In this case, her methylation activity is low. She's making some, but not high enough to keep up with her 2-hydroxy. So basically what's happened is you have a plugged up bathtub. You have all this water in the bathtub, her 2-hydroxy, and she can't drain very fast. In this instance, you can see that COMT and MTHFR run. Again, it's methylation, so it involves MTHFR as well, just not as much. And this person has a COMT issue. So if you could give this woman all the folate and all the B12 in the world, the methyl B12, and while it will be helpful, it will not be ideal. So you want to make sure you know the genetics when you're looking at your phase 1 and phase 2. It can be really, really helpful when guiding your treatment. Do you give DIM for a phase 2 issue? Well, is it a problem at the 2 or the 4-hydroxy? Phase 2 treatments are different than phase 1. DIM and indole 3-carbinol are a phase 1 treatment. But what do you do for treatment? Here you go. Support the SNP. Eliminate environmental sources. General support for high estrogens are things like calcium D-glucarate. Now, calcium D-glucarate helps when you have estrogen moving through the intestines. So beta-glucuronidase will essentially, if you have high beta-glucuronidase in the intestines, that will result in higher estrogen that gets recirculated. Calcium D-glucarate stops that process. Ground flax seeds can raise sex hormone binding globulin and bind up estrogen. Be careful, that may also bind up testosterone, and your general liver support protocols. So sulforaphane and glucoraphanin, again, this is what I mentioned earlier. These are the things in broccoli sprouts. Glutathione or NAC, N-acetylcysteine, that makes glutathione, and resveratrol. Phase 1 support, typically you're looking at DIM and you're looking at indole 3-carbinol. Your phase 2 support, you're looking at magnesium and P5P. P5P is the active ingredient in B6. TMG stands for trimethylglycine, and choline, methionine, SAMe, activated B vitamins. Again, this is a very general list, and it really depends on your patient, their history, and their genetics and what you might choose. So knowing your estrogen metabolism in men and women allows you to evaluate phase 1 and phase 2 differently. Yes, this is absolutely a female lecture, but the phase 1 and phase 2 can apply to your men who are estrogen dominant as well. Okay, let's talk about progesterone deficiency, because this is really super common. Progesterone, 1, address the cause. If she's PCOS, if she's hypothyroid, if she's really high stress, if she's underweight or overtraining, like always go for the cause. But how do you support otherwise? Well, chase tree berry. Chase tree berry, also known as Vitex, is a fantastic herb that helps the hypothalamic pituitary ovarian communication to improve ovulation. The typical dose is about 250 to 500 milligrams a day, often done in the morning, every day, all through the cycle, not just in the luteal phase or just the follicular phase. A lot of providers will do ovarian glandulars, so there are glandular products that you can buy that encourage ovulation. Brain support, like pituitary support, pituitary or hypothalamic glandulars, maca, the herb maca, the Peruvian herb, and cordyceps, really good for brain support. Vitamin B6, the active ingredient P5P, can really help by regulating FSH and LH, and evening primrose oil or borage oil can be really helpful, especially for fertility purposes. You want to be careful, though, especially with evening primrose oil, that it can, in some women, cause uterine contractions. I do have patients that say that evening primrose oil can worsen their cramps, so I use it more in the follicular phase, although not every woman is affected, and if they're not trying to get pregnant, if fertility is not my outcome, then I will do it every day all through the cycle. When you use actual progesterone, if you have a woman that you decide, you know what, you could really use some HRT, some progesterone, if she's still cycling, I tend to do it from a positive ovulation until menses. So basically in the luteal phase, only 14-ish days, roughly. Again, not the point of this talk, but just so you're aware, in perimenopausal and menopausal women, I tend to do 6 days on, 1 day off. Some people do 3 weeks on, 1 week off. Others will do 5 days on and the weekends off. Basically, you're trying to give your menopausal women a break. Hormones aren't on all the time, and so you want to make sure that you give them that relief. And then here, the oral, the sublingual, the topical, and the vaginal doses. And unfortunately, I apologize, the little indention is under the perimenopause, menopause, but the dose is the same regardless of age. So cycling or not, the oral, the sublingual, the topical, vaginal, it's all the same. So you can choose, and these are just guidelines, just somewhere to start. and typical for HRT prescription. All right, let's talk about estrogen deficiency. What happens when your estrogens are too low? Well, again, address the cause. You can still do Chaste Tree. Chaste Tree is known to help raise progesterone. I find it is a fantastic ovarian adaptogen and can absolutely help balance estrogen when it's too low in a cycling woman. Again, ovarian glandulars. You're just trying to get the gland to communicate with the rest of the body and with the brain so that it will make appropriate estrogen levels. We've already talked about brain glandulars and then maca and cordyceps. DHEA, if it's warranted, DHEA can be helpful in raising estrogen. And there are a number of phytoestrogenic herbs. Black cohosh, dong quai, red clover, raponticum. Maca, again, can be phytoestrogenic. Tribulus, the isoflavones, genistein, and of course, the Ayurvedic herb shatavari, which is one of my favorites. If you're going to use estrogen, the dosing is listed here specifically for vaginal dryness, oral estrogen, sublingual estrogen, topical estrogen, vaginal estrogen, and then a pellet. And the way you would do it is similar to progesterone. If she's cycling and you think she needs some estrogen, you may do it just in the luteal phase. You may do it just in the follicular phase, especially if you're trying to help a woman get pregnant. And then, of course, if she's perimenopausal, menopausal, you would do 5 days on, 2 days off, 6 days on, 1 day off, 3 weeks on, 1 week off, just sort of depending on how you practice. But these are general suggestions, the most common that you'll read on compounding pharmacies, just to give you an idea of where to start and maybe some upper ends to consider. Of course, everybody is different. And estrogen does come with risks, so you want to make sure that you do appropriate testing and, talk to your patients about lowering risk. Okay, testosterone deficiency. Address the cause as usual. You can consider bioidentical testosterone and DHEA. And you want to be aware of things that raise sex hormone binding globulin, resulting in your lower testosterone levels. Again, these are things like high estrogen and low thyroid. So if you have a woman with estrogen dominant, too high estrogen, or she's hypothyroid, then that might be the cause of her low testosterone. You want to support testosterone, whey protein if she can eat it. Whey protein can be helpful, especially for improving growth hormone. HIIT training and resistance training. Zinc, of course, this is dose dependent. Maca can be a really great herb. Tribulus, and like I've said before, shatavari. Now, I have shatavari not generally recommend with estrogen dominance because it can cause some estrogens to go up, and I have seen that in practice where I tend to use shatavari more for estrogens that are in the normal range or even on the low range when it also comes to low testosterone. Using testosterone, again, guidelines, oral testosterone is not often that done, or not done that often, I should say. So we move more towards sublingual. We do a lot more topical, a lot of vaginal, especially for orgasm support, vaginal dryness. You do have to be aware of clitoral enlargement. I have had a couple patients that have come to me on very, very high doses of vaginal testosterone, and it has caused their clitoris to enlarge, and unfortunately that's irreversible. A pellet has to be inserted by someone who is trained. But a pellet can be a really great option for some women because once it's in, it can really release the sort of low dose, helpful testosterone. The downside to the pellet is once it's in, and if it doesn't work for her, you have to wait for it to wear out. All right, since we're on the androgens, I do want to talk about sex drive because this is really important, and I really hope you're talking to your patients about sex drive. So these are the questions that I tend to ask when it comes to sex drive. Number one, is your low sex drive a problem for you? Because if she says no, it's not really a problem for me, then what are we doing? Who are we doing this for? Which is number two, is this a problem for your partner? Because if it's a problem for him or her and not a problem for you, then this is something we need to talk about. If it is a problem for her and it's a problem for the partner, then absolutely, let's work on this. Number three, are you still attracted to your partner? Now, listen up. When you ask your patient, hey, are you still attracted to your partner? And they go like this, yeah, there is no pill for that. There's alcohol. Alcohol helps with that. I'm just kidding. So if she's not attracted to her partner, either physically, mentally, emotionally, that is an entirely different thing. That may not necessarily be a testosterone, estrogen, progesterone thing. And you may want to look at not only hormones, but maybe even neurotransmitters, consider having them see counseling or really talk that through. Like, what happened? Did you used to be attracted to your partner and you're not anymore? Were you never attracted to your partner? What's going on at home? Number 4, did you have a sex drive in the past? And was it high and now it's lower or gone? Or was it low and now it's low or gone? And the reason I want to know this is I want to know where their starting point was. So with women and testosterone, there's no like luteal phase, follicular phase, age-dependent range. It just is. There's just like, this is what a testosterone should be in a woman who still gets her period. But the range can be, you know, broad. So if you have a woman in range and she says, I had a huge sex drive, really, really high, and now as I get older, I have crashed. Well, I'm going to treat her a lot more aggressively than somebody who says, yeah, I like sex and I've had an okay sex drive and now it's lower, so I'm just not as interested. I may not have to treat her as aggressively because she didn't start out life with a high sex drive compared to somebody else who may feel better at the really upper end of the range of testosterone or DHEA. So keep that in mind. All right, next question. Does sex hurt? Well, of course, if sex hurts, she's not going to want sex, and then her sex drive is going to be low. If she says yes, you're going to do what you can to assess what's going on. Is it a pelvic floor issue, muscle issue, infection? Does she have a history of trauma? What is going on? And then lastly, can you reach orgasm? Because if it's not even fun for her and she can't reach orgasm, then you want to help her with that. And you also want to ask, could you reach orgasm in the past? Or is this something that's been a problem for you for a long time? Because if she says, no, I can never really reach orgasm, I really never have in my sexual career, then it's maybe not as high on the priority list as compared to someone who says, yes, I used to have orgasms every single time, and now I can't, and it's not as fun for me anymore. You may treat that a little bit different. Speaking of sex drive, make sure you know other factors are involved for women. So attraction is huge, which we've talked about. Arousal is really huge. I've talked to more patients who say, you know, I have no sex drive, but once I get into it, I really like it and it feels good. I just can't get started. You know, like I just don't have that initial, hey, let's have sex. Like they're not instigating it. They're waiting for him or her, their partner, to instigate it. And then once they get going, they're fine. Are her needs being met? There are a lot of people put a lot of stock into that love language, the love language books, and it's all free, it's all online, and I highly recommend couples look into that because if her love language is not being met, then she's not going to feel that attracted to her partner, and she may not have a very much interest in sex. Stress is huge for women. For men, having sex is usually a stress reliever, whereas for women, stress is usually one more, or not stress, sex is usually one more thing to add to the to-do list, and it results in her feeling more stressed out. Hormone balance is, of course, the purpose of this entire lecture. And then neurotransmitters. Really look at neurotransmitters. You may want to consider like DLPA, which is D-L-phenylalanine. So this increases endorphins and dopamine, and that's your reward center. Serotonin alleviates depression and can help with anxiety. And then GABA, of course, can alleviate anxiety. So if her sex drive's low because she's depressed and anxious, you know, maybe it's neurotransmitters and not so much hormones. All right, let's talk about the complete opposite, testosterone excess. How do you treat this? Well, determine if it's a problem. Is she symptomatic? Like I said, some women just are born and have higher levels of testosterone and they feel really good with it. They don't have any other bad side effects, then I don't touch it. Address the cause. Is she on testosterone? Is her partner on testosterone and she's getting contamination from him or her? Does she have PCOS? Does she have high insulin? Is it stress-induced because the adrenals are making too much testosterone? Is it potentially from medications? So you want to definitely look and see what's going on in her back history. Make sure she's not getting transference, which I talked about. And ways to reduce testosterone naturally. White peony can be really helpful. Green tea extract, and of course, general liver support to help detox it out. What about having an elevated 5-alpha reductase or 5-alpha DHT? So maybe her testosterone and DHEA are normal, but she still has facial hair and hair loss and anger and irritation, and it's all due to this pesky 5-alpha reductase. Well, address the cause like we've talked about before. The medications that, depending on her case, are spironolactone and metformin. Finasteride, a lot of people have used or will use, but be aware of finasteride syndrome, and if you're not familiar with finasteride syndrome, please look it up. And then naturally, saw palmetto, stinging nettle root, pygeum, reishi mushroom, and zinc can be really helpful at sort of diverting the alpha to the beta side. The beta is less androgenic and can be really helpful at negating symptoms. Now, keep in mind, when you look at these, you might think, well, Dr. Jones, these are your typical prostate supplements. Yep, exactly. So I will tell women, hey, look, I'm going to put you on this prostate product. Please pay no attention to the title. I just need the herbs and nutrients inside. And especially if she has a partner, be like, hey, warn your partner. It's going to say prostate, but I just need to address the symptoms and get you from an alpha to a beta and you have these resolved. So you're not having facial hair, you're not experiencing hair loss, you're not angry and irritated as you usually are. That's what we're going for. What about elevated prolactin? Okay, so again, the Dutch test does not look at prolactin. This is done in a blood draw. But if you have a woman with elevated prolactin, there are levels to prolactin, how high it is. A prolactinoma will generally have super duper high levels of prolactin. That may require surgery and or medication, so be aware. Chase tree will not help a super high prolactin level due to a prolactinoma. If it's just mildly elevated, you can definitely try chase tree, 250 to 50 milligrams the entire cycle. And of course, address, is she breastfeeding? Is her thyroid a problem? Is she estrogen dominant? Is she under a lot of stress? Those are three big triggers for higher prolactin levels. Cancer. We're talking about estrogen, low progesterone, 5-alpha reductase, all these hormones. Where does this all fit in when it comes to cancer risk? Well, here you go. There are 5 things to look for when you're looking at the Dutch test. Number 1, if she has a low 2-hydroxy with an elevated 4-hydroxy E1 level. So when you're looking at the Dutch test and you're looking at estrogen metabolism, start there. What does her 4-hydroxy look like? And then, number 2, can that 4-hydroxy and that 2-hydroxy get out? So you want to look at her methylation status in regards to phase 2 estrogen clearance. Again, remember, methylation is the act of phase 2 detox, one of them, it's part of it. And it does involve MTHFR, but more importantly, COMT. Low melatonin. Melatonin is a super potent antioxidant and really helpful for helping to reduce cancer risk. So if you're doing the Dutch test and you're looking at the adrenal page, you want to see what her melatonin status is. Number 4, when you're looking at her cortisol results. Now I know this is a hormone, not an adrenal talk, but when you're looking at her free cortisol levels, if she has a flat slope, meaning is it basically a straight line, she does not get that cortisol awakening response, that can result in an earlier mortality for women and even men who've been diagnosed with cancer. And for women, of course, breast cancer, and for men, prostate cancer. And lastly, we want to look at our brand new marker, the 8-hydroxydeoxyguanosine. This is a marker for oxidative stress and DNA damage. The higher it is, it means the more DNA damage she is experiencing. All right, so we talked a lot about these hormones, and I want to move into sort of PCOS, especially because PCOS often gets immediately lumped into an insulin problem when maybe it's an adrenal problem. So PCOS, polycystic ovarian syndrome, it does seem to fall on a spectrum. How many times have you seen a patient or a client and you thought to yourself, well, they look kind of PCOS-ish. They kind of fall on the spectrum. They're not totally, I don't know. Sometimes it involves insulin, and like I said, sometimes it's an adrenal problem. So this is the usual PCOS story. This is your classic PCOS. She comes to you and she says, I started my period later in my teen years, if at all. So maybe she started her like 17, 18, 19, or maybe she says to you, I never started my period. And so they had to put me on the birth control pill. Because, right, all healthcare providers, if you have a problem as a teenager, you go on the birth control pill. Then she says, and then I started getting cystic acne. I was getting hair growth in places I didn't want, the nipple area, the top of my lip, my chin. I don't appreciate this. So the doctor says, okay, we're going to put you on the medication spironolactone or maybe Accutane. She started gaining weight around the middle. She says, I've had a good diet. I do regular exercise, but I can't figure this out. Where is this weight coming from? By the 20s and 30s, her hair starts thinning. It starts falling out. And she comes to you. Why? Of course, because she wants to get pregnant. She says, I've stopped the pill and I never got my period back and I'm ready to get pregnant. And you go, oh my goodness, this is your classic PCOS case. mismanaged, so to speak, on the birth control pill, spironolactone, and Accutane. Now, while those medications absolutely treat the symptom, they're not going to help her later in life when she's trying to get normal, regular cycles and achieve fertility in a healthy manner. So, typical presentation again, androgen excess, hirsutism, hair growth in places she doesn't want. And I am not talking about like, hey, I have the occasional chin hair that's annoying and I have to pluck it. I mean hair growth in places she doesn't want. Around the nipple, between the belly and the pubic bone, on her chin, on her sideburns. Male pattern hair loss, acne or cystic acne, and of course, anger, irritation, mood swings due to these higher androgens. Ovulation issues, anovulation, irregular cycles, oligomenorrhea, fertility challenges, and then lastly, this fancy word called polycystic ovary morphology, PCOM. And basically, this is when you get the multiple cysts on ovary. The diagnosis is 2 out of 3. We tend to follow the 2003 Rotterdam criteria, which says you have to have androgen excess and or ovulatory dysfunction and or PCOM. But 2 out of 3, you don't have to have cystic ovaries to be diagnosed with PCOS. Is obesity part of the diagnosis? I get asked this a lot. Like, well, Dr. Jones, it might be PCOS, but she's skinny. No, obesity is only about 30 to 75%. You can absolutely have what's healthy weight PCOS or even underweight PCOS. It doesn't have to be a part of the diagnosis. If she does have an insulin problem, however, this is the mechanism of action. She gets insulin resistance leading to obesity. She gets this high insulin in her bloodstream. High insulin, of course, lowers sex hormone binding globulin, and that raises testosterone. In addition, that high insulin pushes on the theca cells in the ovaries, and the theca cells make more testosterone. So now she has all this testosterone floating around because of her insulin. With enlarged theca cells and high testosterone, she gets antral development that stops, and therefore she doesn't ovulate. That results in low progesterone, and now she's probably estrogen dominant. But remember, as we talked earlier, it's not just an ovarian problem. The ovaries and the adrenals make testosterone and androstenedione and DHEA. So you may think it's an ovarian issue, but really it could be an adrenal issue. Other commonly run labs, of course, you want to look at her glucose or insulin, her hemoglobin A1C, or 2-hour insulin glucose tolerance test if you do it. You want to look at her thyroid complete with antibodies and reverse T3. Why do you want to look at her thyroid? Well, because if she's having irregular cycles or no cycles or anovulation, weight gain, that can all be a thyroid problem too. You want to look at her prolactin, same thing. If she has a mildly high prolactin or even a moderate or high prolactin, that will cause irregular cycles or anovulation or no cycles. You may want to consider looking at her FSH and LH. Potentially, you want to look at cardiac markers just for risk mitigation, especially if blood sugar and insulin are involved. You could consider looking at 17-hydroxyprogesterone. This is one of the tests for congenital adrenal hyperplasia, CAH. What will happen is this marker will be really, really high, and the cortisol will be low. And so you want to suspect, and then she has all the typical presenting symptoms of PCOS. Anti-Mullerian hormone, so anything over 4, you want to suspect PCOS if it's nanograms per milliliter. And then, of course, consider a pelvic ultrasound. And if she looks like she has these teeny tiny little cysts, they call it a string of pearls, then it's probable PCOS. Now, here's a case that kind of highlight all of this. So this is the case of a woman. She was 38. This is a patient of mine. She's 38. She was a stressed out PhD student, married mother of 2. She had a recent onset of irregular cycles the last 6 months. She had some acne and hair thinning, and she had a lot of gut issues. She was diagnosed with SIBO. So irregular cycles in the last 6 months, high stress, some acne and hair thinning, a lot of gut issues. She had been told she had PCOS, and she needed to do something about it. She's like, I don't think I have PCOS. I'm going to go see my naturopathic doctor. And so she came to see me. So this is what it looked like on her Dutch test. Her progesterone was low in the red circle. In the next red circle, we look at her estrogen. So her estradiol was at the upper end of range, and her estrone is actually high. So she's estrogen dominant. Her DHEAS is high. Her testosterone is high. She looks very classically PCOS, right? Estrogen dominant. She's not ovulating. She's at irregular cycles the last 6 months. So I could see why her doctor said, hey, you have PCOS. She fit 2 out of the 3 criteria. Then I ran her cortisol markers. Turned out she's making a ton of cortisol, 10,245. Then you look at her free cortisol, 304. And you can see she spikes really highly in the morning, which of course is a combination of stress. She's trying to get 2 kids out the door and herself to a PhD program. And she has a lot of inflammation. She has SIBO. So if she eats in the morning, she's affecting her intestines. She doesn't feel good. And so her cortisol goes up as a result. Now, because her cortisol goes up so high and her adrenals are hyperreactive, they're going to dump all the androgen hormones too, testosterone, DHEA. It's entirely possible this is an adrenal issue. So the questions are, where do you start? What do you do? And is this really PCOS? PCOS is in like the classic ovarian PCOS. What are the goals? Well, address the cause, of course. Focus on diet and lifestyle, address blood sugar and insulin, improve cortisol levels, restore ovulation and improve estrogen balance, and then reduce androgenic symptoms. This is what the plan of attack for your PCOS patients. How do you address blood sugar and lifestyle factors? There are a number of supplements that I have listed here, the most common that can be helpful. Berberine, of course, is used a lot, 500 milligrams 3 times a day with meals. And berberine has been shown in the research to be kind of as effective, if not more effective, than metformin for blood sugar and insulin balance. I do have metformin listed at the bottom because a lot of practitioners will just go ahead and put a woman on metformin to help right away, but berberine might be just as effective. Also remember, berberine is really great for gut bugs. So if you're trying to kill gut bugs, berberine can help that and blood sugar. Inositol is one of my other super favorite ones. I know a lot of practitioners will use D-pentatol. I find inositol, just plain old inositol, cheaper and can be just as effective. When it comes to working out, you're looking at weight training, heavy lifting, and resistance training. You want to use your muscles to burn insulin if that's the issue. You're not looking to do cardio. Cardio is what puts you into that catabolic state, or like you're running from the tiger. You want to be heavy lifting. You want to address the stress, of course, address the cause, work on meditation, go see acupuncture, start journaling, see a counselor, find joy and happiness. And of course, the most important thing, proper sleep hygiene. If you're not sleeping well, if you're on your phone, your computer, your tablet at night, and you're not using the blue blocking glasses, you could have a real problem. Consider adaptogens, adaptogenic herbs like ashwagandha and eleutherococcus. And then, of course, there are calming support too, like phosphatidylserine, holy basil, magnolia skullcap, theanine, and this is just a short list. There are a number of herbs that are really helpful at stress and cortisol, but this is just to give you an idea of where to start, some doses, but of course you can branch out from there. You want to improve ovulation and raise her progesterone. How do you do that? Well, consider chaste tree. Have chaste tree 250 to 500 milligrams every day. Consider vitamin B6 to help with that FSH, LH, serotonin, help with building progesterone. Now, false unicorn root, I want you guys to be very, very aware. This is threatened, a threatened plant, and so a lot of herbalists suggest not using it at all. It can be effective. If I'm going to use false unicorn root, I tend to use it only after I've tried everything else, and especially if she's trying to get pregnant. Otherwise, I use maca. Maca is a really good substitute for false unicorn root. And so the maca dose is there. Even in primrose oil we've talked about. And of course, you could consider doing luteal phase progesterone, topical, oral, sublingual, vaginal, and then acupuncture. A lot of great research on acupuncture and improving ovulation. How do you reduce the androgens? All the things we've already talked about. So addressing the insulin and the cortisol, because you want to make sure that the ovaries not making too much androgens and the adrenals are not making too many androgens. Spearmint tea. Who knew? Spearmint tea, of course, is a great anti-androgenic blocker for women. So have her drink spearmint tea. And then we have the 5-alpha blockers. I have blockers in quotes because really what it does is it kind of, like shifts, it reduces the alpha and, pushes more towards the beta, and that's what you're going for. It's not a true blocker. The levels won't be 0. But saw palmetto, zinc, stinging nettles, pygeum, which is a bark, Africanum bark, and then reishi mushroom. So that patient I talked about, my 38-year-old PhD patient, what did I do for her? Well, it turns out I decided, you know what, you are under very high levels of stress and you have this gut infection. So I know you're very, very inflamed. So high stress and high inflammation. I'm assuming that drove up her cortisol, triggered her adrenals, and the adrenal androgens just dumped out. So what I did is I focused on the gut first because, everything starts with the gut, duh. And then stress reduction. I know she's a PhD student. We're just trying to keep her head above water. I know she's a married mother with 2 kids, and life is just busy right now. And so I said, we're going to treat the gut, focus on things to reduce stress, find ways to find help, lean on your husband, do things that make you happy, um, say no. Say no to things. Stop volunteering for things because right now in this PhD program, you just can't take it on. I did add 500 milligrams of Chase Tree for her, and I added 20 milligrams of P5P. And in 3 months, her periods resumed normally, and she felt much improved. Probably not your classic PCOS. I would not have diagnosed her with PCOS. I think it was situational. The stress and the gut just affected everything else. All right. Thank you so much for listening to this talk today. I hope that you learned a lot, and please, if you have any questions, feel free to call the office. You are welcome to look up on our website as well. It's www.dutchtest.com, where we will have lots of other educational videos for you.